Melanoma is the most dangerous type of skin cancer and is a malignant tumor which forms in the melanocytes that are responsible for the pigment of the skin. A cancer that afflicts people all around the world, the dangers of melanoma arise from how unnoticeable it is, as well as the potential it has to metastasize to other parts of the body. Looking almost like a mole, melanoma is very hard to catch by eye because of how common it looks on the surface of the skin. When individuals have birthmarks, scars, moles, and lesions on the entire surface of the skin, it is very hard to differentiate a melanoma from a benign mark in the early stages of formation. If it is detected early, it is almost always treatable, leaving the patient virtually unscathed. But the melanoma packs a double punch. Because it is so hard to visually distinguish a melanoma in the early stages, most metastasize to different parts of the body, such as the lungs, via the lymphatic system. This is when melanoma proves to be fatal, when it has a chance to spread. More than half of all melanomas diagnosed are invasive melanomas, leaving the patient needing critical care. Now the next question would be, how are melanomas diagnosed other than visual cues? As it turns out, the only other way is a skin or excisional biopsy. These biopsies are only recommended once some sign of a melanoma has been detected, and therefore, this is not a routine procedure. Imagine having to biopsy every patient going to his or her primary care physician or dermatologist about a mole that just appeared. Medically, it wouldn't make sense. But at the same time, this is the reason that melanomas are being missed in the early stages and are getting the chance to metastasize and cause harm. There is no commonplace, quick, outpatient test which can be performed to immediately give results on whether a patient has this type of skin cancer or not. There's no test that can quickly be administered to any patient coming in saying that they noticed a new mole, or a test that doesn't involve the pains of a biopsy. There is no test that is routinely integrated in the practice of the primary care physician to catch melanoma very early before it has a chance to spread. And this is critical, keeping in mind that in patients who have stage 1 melanomas, the 5-year survival rate is around 95%, while patients with stage 2 or stage 3 melanomas have a 5-year survival rate of only 50%. By the end of stage 2 and in stage 3, the primary tumor has grown in size and parts have metastasized, leading to a decreased survival rate. Stage 4 patients ultimately have a 5-year survival rate of only 17%. We need to make sure these patients get diagnosed early so that the odds aren't stacked against them. My idea is to create a simple outpatient diagnostic procedure that can catch melanoma in the very early stages. No biopsy would be needed in order to get a positive or negative result on whether a questionable spot is a tumor. It would be routine, allowing for more and more patients to be screened as a safety net to catch melanoma cases before they have the opportunity to get much worse. My inspiration comes from two sources, the Congress as well as my personal life. Jack and Draco was my inspiration from the Congress in February. Listening to his presentation about creating non-invasive and accurate mechanisms for diagnosing pancreatic cancer, I immediately was hooked on the concept of biomarkers. I knew that they could be used for analytics in terms of diseases, but I was amazed at the fact that the sensor he created was so sensitive to these biomarkers that exist in minuscule amounts in the blood. Seeing him standing on the stage inspired me to pursue some of my own ideas, including this one. Furthermore, his work with biomarkers got me thinking on other types of markers that might exist out there in order to detect different types of diseases. This inspiration, as I mentioned, was coupled with the situation that had occurred in my personal life. I had met a patient with melanoma, and around 2 years before I met him, he had gone in for a routine checkup with his primary care physician. He told the physician that he noticed a small mark on the dorsal side of his forearm, but it was waved off with no follow-up done. About a year after, he came in for another checkup and mentioned the mark again. The doctor sent him for a biopsy, and the test came back that he had stage 2B melanoma. Luckily, they caught it before it had metastasized to the nearby lymph nodes. The patient still had to have surgery to remove the localized tumor, and ever since, he has been going through chemotherapy and radiation therapy. Yes, it is true that he was ultimately diagnosed, but if the diagnostic procedure was quick, cost-effective, and simple to do, his primary care physician could have tested for the problem through a routine procedure before it got much worse. It opened my eyes to the perils and qualms of diagnostics and how the medical community can improve these procedures for their patients. So many times, the medical community tries to diagnose harder instead of diagnosing smarter, missing the whole point of finding out exactly what is wrong with the patient. Our tests are so cumbersome and not created in a way that they can be routine enough to catch the real problem. An individual who I had once known, explicitly familiar with military affairs, once told me something interesting which propelled me to embrace this idea further. He said that there are two ways to find a sniper in the heat of war. Either you can deploy helicopters, planes, ground troops, and radar to try and find the sniper, and hope that the sniper shows up on one of those detection mechanisms. Or you can be alert and look for the telltale sign of the presence and location of a sniper, the location of the light from the muzzle fire of the sniper. Don't look using everything, look for the right things, he said. In completing the analogy, this is how I approach the diagnosis of melanoma. We look for the telltale sign, the muzzle fire, to give melanoma patients the real chance that they should have. My hypothesis relating to creating a quicker and more cost-effective way of diagnosing melanoma revolves around the fact that cancer cells are not like normal cells. Repeated tests have proven that cancer cells produce different volatile organic compounds depending on what type of cancer is present. Volatile organic compounds, or VOCs for short, are organic compounds that are both produced naturally in animals and plants as well as man-made in the laboratory setting. In the case of melanoma, these VOCs are being directly excreted onto the skin of the patient. If these VOCs for melanoma can be detected on the skin of the patient, any lesions, bumps, or abnormalities of the skin of the patient can be quickly checked to see if they are cancerous or not. In fact, in recent studies, dogs, which can smell in terms of parts per trillion, have had a 98% success rate in terms of detecting very early stage cancer in patients that the dogs were exposed to. It was theorized that this may be a result of a compound that the dogs were smelling, something like the VOCs. Keeping this in mind, my hypothesis is that if I can analyze compounds on the cancerous area of a melanoma patient, then I can identify what compound is being produced by the melanoma that differs from the normal compounds produced in a healthy patient. This would be the telltale sign that I was previously talking about. An organic chemical that is present only in the development of melanoma would allow us to differentiate between benign-looking masses and ones that are harmful. Because a mass in general will produce these organic chemicals, early-stage melanomas would produce the same VOCs, allowing us to detect in these stages when the cancer is treatable. Once this is established, I can create a test that harmlessly reacts on the skin of the patient with the melanoma in the visual manner that the doctor can observe. This would be almost like staining, without the permanent effects. A color change in the test would easily tell the doctor administering the test whether a melanoma is present at that location or not. The solution, as partially touched on in the previous section, is to create a diagnostic test that can recognize the unique volatile organic compound produced by melanoma in order to catch the tumor. The diagnostic test will be an aerosol liquid made up of a harmless chemical which can react with a specific volatile organic compound. The liquid can be sprayed onto the spot in question, and a color change in the liquid will occur immediately if the volatile organic compound is present, visually alerting the doctor of the presence of a melanoma. In terms of the implementation plan, I look at this in two phases. The first phase will be to isolate the VOC that can differentiate a patient with melanoma from a patient without melanoma. My procedure would begin by taking samples from patients known to have melanoma and patients that are completely healthy with no pre-existing conditions, as well as a family history of any other diseases. This healthy patient group will serve as a control. The samples would be of the surface of the skin of the patients. For the melanoma patients, it will be on the site of the cancer, and for healthy patients, it will be randomized on different areas of the skin. The objective is to control as many variables as possible to make sure that the correct organic compound is being isolated, and that there is a clear and unique difference in anything produced by the melanoma. In order to get accurate results, the collections of the sample would be in relatively large quantities. Taking samples from 100 patients with melanoma across all 4 stages and taking samples from 100 patients who are healthy will allow for results that can be corroborated. Running these samples through a gas chromatography or a mass spectrometry machine will allow me to identify and isolate the compound that is different between the two groups. Again, the compound would be a clear indication of melanoma in order for the diagnostic test to be effective. The second phase of the procedure is to create a test that can identify this compound that I project to find. The volatile organic compound that I project to find, as characteristic of melanoma, is an organic chemical, so it can react with other substances. Figuring out what type of chemical can react with the VOC related to melanoma will be the base of the diagnostic test. This chemical has to be harmless to the patient and should react with the VOC and change color in order to visually render results. Furthermore, the substance that reacts with the VOC has to react quickly so that the results can be immediately assessed. Once a correct chemical has been tested to produce a reaction and color change, and it has been isolated, I would aerosolize it so that the test can be quickly administered with minimal risk of contaminants altering the results. At the same time, aerosolizing would decrease contact with the skin of the patient, so if there are any open cuts or fluids, it would be safer to use a procedure where the doctor does not need to physically touch the patient in this situation. The final step has to be to test the diagnostic procedure that has been created in a clinical trial that would include 100 patients with melanoma across all 4 stages and 100 patients who are healthy. Success rates in these trials would be measured to finally determine whether the test is accurate and viable for the medical community. The impact of such a diagnostic test is huge. Thinking of it as a safety net, more of the population can be screened in order to find the cases of melanoma that are slipping through our fingers until it is too late. In cancer care, earlier is always better, and a routine diagnostic procedure makes sure that it can be as early as possible. Doctors will be able to receive definitive answers on whether the patient has melanoma without having to consider the ramifications of such a test. In terms of a biopsy, more often than not, doctors are reluctant to send all suspicious cases they see for this test because they don't want their patients frustrated with the fact that they have to get pieces of their skin removed for a result that just came back negative anyway. My uncle, an oncologist, tells me that he is very conservative about doing a biopsy until he is absolutely sure that there is some sign of a malignant tumor. But oftentimes, by then, the melanoma has grown and metastasized. Alongside this, doctors cannot just send every patient with a mole or lesion to get a biopsy done because it wouldn't work for the patient or the medical community. Speaking with my uncle on this matter, he said that such practice of devoting the time and energy of a biopsy to every suspicion of melanoma would not be practical and would just lead to more problems. We need a better test, and through my hypothesis, solution, and implementation plan, I have created and shown the path of something that is just that. 1 in every 3 cancers diagnosed is a skin cancer, and 1 in every 5 Americans will be diagnosed with a skin cancer in their lifetime. These cases need to be found and treated before it is too late. This brings me to talk about what this solution and the data collected could do for any closely related work. This would include any further avenues of research. Analyzing the volatile organic compounds of melanoma would just be the first step. There are a multitude of cancers out there that can be manageable and even treatable in patients if they are detected early. The concept of looking for organic compounds produced by cancer cells can apply to different types of cancers in order to detect much earlier. Alongside with cancer, future research can open up whether bacterial infections or host cells of viruses produce different organic compounds than a set of normal cells. Our tests for diseases could be streamlined and efficient to the point where we wouldn't have to wait hours for sometimes days to determine whether a patient has leukemia or a staph infection. I believe that we are at a turning point in medicine where the protocols that we use for diagnosis are going to be revolutionized. We're going to travel into an age where technology enables us to create and conduct diagnostics that are smart, quick, accurate, cost-effective, and a huge improvement on what currently exists today. Jack and Draka is a prime example of what the future of diagnostics looks like, and it is a very positive future indeed. My solution for melanoma diagnostics, as the National Academy puts it, is a challenge of theory, projections, and expected results for a chance to change the world and create value. With my research and understanding, I do see the potential for the idea that I have thought of, as well as paths on which further research can go to broaden and expand the scope of my original idea. I thank the National Academy of Future Physicians and Medical Scientists for this exciting opportunity. I thank Mr. Rossi, his team, and all the members that were able to put the Congress together, and I thank my parents, teachers, friends, and supporters for believing in my dreams and me. You have all inspired me to not only become a part of medicine, but to chase those core ideas of striving to create meaning and value. Thank you.